It is a staggering, deeply unsettling truth that thousands of men and women who risked everything for this country are actively walking away from the healthcare system designed specifically for them. We are talking about the Department of Veterans Affairs, the VA, a massive federally funded institution that is supposed to be the bedrock of post-service life. But the exodus is real. Every year, countless veterans, many of them critically injured or struggling with invisible wounds, are choosing to navigate the brutal, expensive, and confusing private healthcare world. Or worse, going without care entirely because the system built to serve them has simply become too difficult to use. This isn't just about minor inconveniences. This is a crisis of trust, access, and competency that is driving veterans to desperate measures. We need to understand the core failures that lead a combat veteran to say, "I'd rather pay thousands of dollars than step foot in that clinic again." Today, we're dissecting the 8 definitive reasons why veterans are quitting VA care in droves and revealing the surprising and often expensive alternatives they are adopting just to stay healthy, or sometimes just to stay alive. The first, and perhaps most infamous reason veterans quit, is the soul-crushing, often dangerous reality of dissecting, appointment wait times, and inescapable bureaucracy. When you are dealing with a potentially service-connected cancer diagnosis, or when the darkness of severe depression is closing in, waiting 6 weeks for an initial consultation is not just inconvenient. It is a life-threatening failure. The VA perpetually struggles with staffing levels, particularly in specialized fields like neurosurgery, endocrinology, and high-level mental health trauma. The official VA statistics often paint a rosy picture, claiming wait times are manageable, but those numbers are frequently skewed, measuring the time from when the appointment is scheduled to when it happens, rather than the time from when the veteran requested the appointment to the date of service. The real-world experience starts with a phone call that often leads to a labyrinthine automated menu, followed by a lengthy hold time, only to be told that the soonest available slot is months away. This initial barrier, the friction point of access, immediately filters out veterans who are already struggling with motivation, mobility, or chronic pain. The sheer effort required to even schedule care becomes a deterrent greater than the illness itself. If a veteran needs a simple procedure, they might be required to see their primary care provider, PCP, first, who then refers them to a specialist, who then refers them to imaging, and only after those 3 separate multi-week appointments are complete can the actual treatment plan begin. This sequential, slow-motion process is a hallmark of the VA system, designed more for administrative compliance than patient expediency. Contrast this with the private sector, where a referral can often be initiated and completed within the same week. The bureaucracy doesn't stop at scheduling, it permeates every interaction. Prescriptions require multiple approvals, travel reimbursement forms, beneficiary travel, are notoriously complex and slow to process, and transferring records between VA facilities, let alone between the VA and private doctors, is often a manual, fax-driven nightmare in the digital age. Veterans often report arriving for appointments only to find their medical file is incomplete or that the specific test results required for that day have not yet been uploaded or reviewed by the physician. This constant cycle of administrative failure forces veterans to become their own case managers, spending hours on the phone, tracking down paperwork, and fighting the system, all while they are supposed to be focusing on recovery. For a veteran with limited energy due to chronic illness or TBI, this relentless battle with red tape is simply unsustainable, leading many to conclude that the stress of accessing the care outweighs the benefit of receiving it. They surrender not because they are better, but because they are exhausted by the fight. The structural inefficiency is, in essence, a form of soft denial of service, subtly pushing the most vulnerable veterans out the door without ever having to officially deny their claim. The frustration culminates when a veteran misses an appointment, often due to travel, difficulties, or a bureaucratic mix-up, and is then penalized, sometimes having to wait even longer for a rescheduled slot, compounding the sense of futility and disrespect that fuels the decision to quit the VA system entirely. The second major driver of this exodus is the deceptive notion of financial disincentives and the hidden costs of free care. Many civilians assume that VA health care is entirely free for all veterans. This is simply untrue. While service-connected disabilities, SC, and low-income status often qualify a veteran for cost-free treatment related to their specific SC conditions, the reality is far more complicated, creating unexpected financial burdens that push veterans into the private market. Veterans who are not 100% service-connected or those whose income exceeds certain thresholds are often subjected to co-pays for prescriptions, primary care visits, and specialized services. These co-pays, while often lower than private insurance deductibles, can accumulate rapidly, especially for veterans managing multiple chronic conditions. Imagine a veteran managing diabetes, PTSD, and a back injury. Each prescription refill, each visit to the endocrinologist, the mental health counselor, and the physical therapist incurs a separate copay. Over the course of a year, these fees can easily total thousands of dollars, an unbearable strain for veterans living on fixed disability income or struggling to re-enter the civilian workforce. Furthermore, the true financial drain often comes from indirect costs. Travel is a massive hidden expense. While the VA offers beneficiary travel, BT reimbursement, the process is notoriously slow, complex, and often only covers a fraction of the actual cost of gas, tolls, and parking. Many VA facilities are located in major metropolitan areas, requiring veterans in rural areas to drive hundreds of miles round-trip. This means time off work, unpaid time, plus the immediate outlay for fuel and lodging if the trip requires an overnight stay. The veteran might receive a small reimbursement check months later, but the immediate financial hit and the opportunity cost of lost wages are immediate and real. This system creates a perverse incentive. Veterans in rural areas, often the most geographically isolated and in need of specialized care, are the ones who face the greatest financial hurdle to access it. They calculate the cost of a 400-mile round trip, the day of lost wages, the complexity of the BT claim, and compare it to finding a decent, if expensive, local private doctor. For many, the local option, even with a high deductible, feels less financially risky and less emotionally draining than navigating the VA's reimbursement maze. The final financial disincentive relates to medications. While the VA generally provides medications at a low cost, they often adhere strictly to a specific formulary. If a veteran requires a cutting-edge or specialized medication not on the VA's approved list, they face a lengthy appeal process or must pay full price out of pocket. In the private sector, a veteran with good commercial insurance might be able to access the latest drug much faster, even if they have to meet a deductible first. The inability of the VA to adapt quickly to new pharmacological treatments forces many veterans with complex conditions to seek private prescribing physicians, thus abandoning the VA system entirely for that crucial aspect of their care. This leads us directly to the third, deeply troubling reason for the exodus: the crisis of trust stemming from misdiagnosis and systemic medical mistakes. For many veterans, the VA is not just a health care provider, it is the entity that determines their service connection and disability rating. This dual role creates an inherent conflict of interest that veterans feel deeply, especially during compensation and pension, C&P, exams. Veterans often perceive, sometimes rightly, that the VA's primary goal is to minimize liability and costs, which can translate into dismissive or incorrect diagnoses. This skepticism is often tragically warranted. The VA system, due to its size and internal pressures, has struggled with quality control, leading to high-profile scandals involving surgical errors, delayed cancer screenings, and diagnostic failures. Veterans frequently report feeling rushed during appointments, particularly with primary care physicians who are attempting to manage massive caseloads. This haste often results in symptoms being glossed over or attributed incorrectly. A classic example involves traumatic brain injury, TBI. The subtle, long-term cognitive and emotional effects of TBI are often misdiagnosed as post-traumatic stress disorder, PTSD, or general anxiety. While both conditions require treatment, the underlying neurological issue of TBI demands a different approach: specialized cognitive rehabilitation, speech therapy, and focused neurological assessment that a PTSD diagnosis alone will not trigger. When a veteran is repeatedly told their physical symptoms are just anxiety or part of the PTSD, the trust erodes completely. They feel unheard, invalidated, and actively harmed by a system that refuses to look deeper. Furthermore, the turnover rate among VA staff, particularly highly qualified specialists, means veterans often see a new doctor every few months, forcing them to recount their entire military history and trauma narrative repeatedly. This re-traumatization is exhausting and unprofessional. Imagine having to detail the most painful moments of your life to 5 different doctors in 1 year, knowing that none of them have the context or history to truly understand your case. This lack of continuity of care is a fundamental flaw. When a veteran seeks private care, they are often looking for a consistent relationship with a doctor who specializes in complex trauma and is willing to invest the time required to build a comprehensive medical picture. They are looking for a doctor whose primary allegiance is to their health, not to the government's budget. This search for competent, dedicated care, free from the shadow of the C&P examiner's skepticism, is a powerful motivator for leaving the VA. The perception that the VA is minimizing their injuries, whether intentional or accidental, is enough to send thousands running to alternatives. The fourth point, intrinsically linked to the crisis of trust, is the devastating mental health access gap and the shortage of specialized care. The demand for mental health services among the veteran population, particularly for conditions like PTSD, military sexual trauma, MST, and severe TBI-related mood disorders, far outstrips the VA's capacity to deliver high-quality, individualized care. While the VA has made strides in awareness and crisis intervention, the structural problem lies in the availability of specialized, long-term, and consistent therapy. Many VA facilities rely heavily on group therapy models or medication management appointments, which, while beneficial for some, are insufficient for veterans requiring intensive individual modalities like cognitive processing therapy, CPT, prolonged exposure, PE, or specialized trauma-focused therapies. The wait list for individual therapy with a trauma specialist can be months long, and once the veteran is in treatment, the sessions are often limited in frequency or duration due to the therapist's overwhelming caseload. Veterans who have experienced MST face an even greater hurdle. Finding a female or male therapist specifically trained in MST who can provide a safe and consistent environment is incredibly difficult within the VA system. The lack of culturally competent care, understanding the unique stressors of combat, transition, and military culture, often means that even when a therapist is available, they might not be the right fit, leading to frustrating and unproductive sessions. The revolving door of mental health providers within the VA is another critical failure point. Veterans often begin to establish a therapeutic alliance with a counselor, only to have that counselor leave the VA system due to burnout, administrative frustration, or better pay in the private sector. This forces the veteran to start over, sharing their deepest traumas with a stranger yet again. This instability is antithetical to effective trauma recovery. When veterans quit VA mental health care, they are often seeking immediate, specialized, and confidential access to therapists who are experts in military trauma. They turn to private practices that specialize in intensive outpatient programs, IOPs, or even residential treatment centers, often incurring massive out-of-pocket expenses because they understand that waiting for the VA to catch up is a risk they cannot afford to take. The desperation for immediate, specialized help when facing a mental health crisis is perhaps the most urgent driver of the VA exodus, as the cost of delayed care in this area can be measured in lives lost. Recognizing these systemic failures, the VA attempted a massive structural fix, which brings us to the fifth reason for the exodus: the failure of the Community Care Programs, CCP. The VA Mission Act, designed to allow veterans to seek private care when the VA couldn't meet certain standards, like wait times or distance, was supposed to be the safety valve. It was intended to integrate private providers into the veteran care network, providing flexibility and speed. Instead, for many veterans, community care has become a bureaucratic black hole, often worse than the VA system itself. The process of getting approved for community care is the first major hurdle. A veteran must first see their VA primary care provider, who must determine if the veteran meets the eligibility criteria, usually that the VA cannot provide the service within 30 days or the veteran lives too far from a VA facility. This determination process itself can take weeks. Once approved, the VA sends the referral to a third-party administrator, TPA, like TriWest or Optum, who is then responsible for finding an available private provider, scheduling the appointment, and ensuring the VA authorizes payment. This handoff is where the system often collapses. Referrals get lost between the VA and the TPA. Private providers, who are often paid less by the VA than by commercial insurance, are hesitant to take VA patients, leading to long delays in placement. Veterans frequently report waiting months for the TPA to find a provider, only to be told the provider is no longer accepting VA patients or that the authorization window has expired, forcing them to restart the entire months-long process. Furthermore, the coordination of records between the private provider and the VA is abysmal. The private doctor performs a test or initiates a treatment, but getting those results back into the VA system, which is crucial for continuity, especially if the veteran needs VA medication refills or follow-up, is often impossible without the veteran acting as the courier, physically carrying discs or printed reports between offices. This lack of seamless integration means that community care often fragments the veteran's health record, making their overall care picture incomplete and creating dangerous gaps in treatment. The final insult is the clawback phenomenon. Veterans receive care through a private provider, believing it is fully authorized, only to receive a massive bill months later because the TPA or the VA claims the authorization was improperly processed or expired. This financial stress, coupled with the administrative chaos, leads veterans to view community care not as a solution, but as an additional complex layer of bureaucracy that creates more problems than it solves. They realize that if they are going to deal with the private sector anyway, it is faster, cleaner, and less risky to simply bypass the VA entirely and pay out of pocket or use their own private insurance. As veterans abandon the community care nightmare, they are increasingly turning to truly autonomous private healthcare models, particularly direct primary care, DPC, and concierge medicine, which constitute the sixth major alternative. This shift represents a fundamental rejection of the volume-based fee-for-service model inherent in both the VA and traditional private insurance. Direct primary care operates on a subscription model. The patient pays a fixed monthly fee, often $75 to $150, directly to the physician. In return, the patient receives unlimited primary care access, including same-day or next-day appointments, extended visits, often 30 to 60 minutes, direct access to the doctor via text or email, and often steeply discounted lab work and generic medications dispensed in-office. For veterans, this model is revolutionary. It solves the three biggest pain points of the VA: access, time, and continuity. Imagine a veteran with chronic pain who needs frequent adjustments to their medication or a quick check-in. In the VA, this might require a multi-week wait for a 15-minute slot. In a DPC model, they can text their doctor, often receive a response within hours, and be seen the next day for a comprehensive, unhurried visit. This personalized, high-touch approach restores the dignity and respect that many veterans feel is stripped away by the VA's assembly line approach. Concierge medicine is similar but often targets specialized care or higher income brackets, providing even greater levels of personalized service and access to exclusive diagnostic tools. While DPC is not free, many veterans find the predictable monthly cost and the guarantee of immediate, high-quality care to be a worthwhile investment, especially when they calculate the indirect costs, time off work, travel, stress, of using the VA. For veterans with higher disability ratings who rely on the VA for most of their specialized care, DPC serves as an invaluable, reliable medical backup, a place to go for acute illnesses, preventative care, and immediate screenings, allowing them to reserve the VA for the complex, service-connected specialists that are too expensive to access privately. This choice is driven by a desire for autonomy and control over their healthcare narrative. They are tired of being a number in a massive system. They want a doctor who knows their name, knows their history, and is accessible when they need help, not when the schedule dictates. This shift reflects a profound disillusionment where veterans are essentially privatizing their own primary care because the promise of federal care has proven unreliable. The seventh alternative, which speaks volumes about the VA's failure to address complex, multi-systemic injuries, is the increasing reliance on holistic, functional, and alternative therapies. Many service-connected injuries, particularly those stemming from environmental exposures like burn pits or Gulf War chemicals or blast injuries, TBI, are complex and defy easy treatment with standard pharmaceuticals or traditional physical therapy. Veterans often find that the VA treats symptoms, prescribing opioids for pain, antidepressants for mood, and sleeping pills for insomnia, without ever addressing the root cause of the systemic inflammation, hormonal imbalance, or neurological damage. Frustrated by this purely symptomatic approach, veterans are quitting the VA in search of functional medicine practitioners, specialized nutritionists, chiropractors, and integrative health clinics. These alternative approaches focus on restoring the body's natural balance through rigorous dietary changes, targeted supplementation, detoxification protocols, and non-pharmacological interventions. Examples include hyperbaric oxygen therapy, HBOT, for TBI, specialized neurofeedback training, and advanced peptide therapies. While some of these treatments are slowly being introduced into select VA research programs, they are generally not standardly available and are often dismissed by VA doctors trained in conventional medicine. Veterans pool resources, use private funds, and travel across the country to access these treatments because they offer hope of true recovery, not just management. This movement is particularly strong among veterans dealing with chronic multi-symptom illnesses, CMI, where the VA's approach often leaves them feeling like medical outliers. The irony is that many of these alternative therapies focus on the core issues of inflammation and brain function that are directly linked to combat stress and blast exposure. By seeking these treatments, veterans are demonstrating a proactive search for solutions that the established system refuses to validate or fund. They are essentially investing their own capital and time into research and treatment that the VA should be providing, driven by the belief that their long-term health is more important than the government's approval of the treatment method. This willingness to pay for unproven by VA standards or non-traditional care underscores the depth of their dissatisfaction with the conventional options offered by the VA. Finally, the eighth and most tragic consequence of this exodus is the ultimate human cost. What happens when veterans go untreated or fall through the cracks. Quitting VA care is not always a choice leading to a better alternative. Often, it is a desperate act of surrender that leads to total disengagement from the healthcare system. For every veteran who successfully transitions to DPC or specialized private care, there are many more who simply stop seeking help altogether. They quit because the VA wait times were too long, the bureaucratic fight was too hard, or the misdiagnosis shattered their trust. Once they are outside the system, the safety net is gone. These are the veterans who are at the highest risk for acute crises. Untreated chronic pain often leads to self-medication with alcohol or illicit substances. Unmanaged PTSD and severe depression escalate rapidly, increasing the risk of suicide. The lack of routine preventative care means treatable conditions like hypertension, diabetes, and early-stage cancers are missed, leading to catastrophic late-stage diagnoses that are far more difficult and expensive to treat. The VA, despite its flaws, is still a major gateway to social services, housing assistance, and disability resources. By quitting the VA medical system, veterans often inadvertently sever their connection to these vital supports, accelerating their descent into instability, homelessness, and isolation. This is the hidden tragedy of the VA exodus. The system is so poorly managed that it actively pushes away the very people who need its services the most, leaving them to face their complex service-related injuries alone. The narrative of veterans quitting often implies they found a better solution, but for a substantial portion, quitting the VA means quitting care entirely. It is a surrender to hopelessness, a final recognition that the promise made to them upon discharge, that their country would care for them, has been broken, not by malice, but by systemic, entrenched incompetence and bureaucracy. This failure to retain veterans in care is not just a healthcare problem. It is a profound moral failing of the state, resulting in increased mortality, familial dissolution, and the continued suffering of those who sacrificed the most. The thousands of veterans walking away from the VA are not doing so lightly. They are making a cost-benefit analysis that reveals a deeply broken system. They are weighing the administrative burden, the financial uncertainty, the risk of misdiagnosis, and the trauma of repetition against the promise of free care, and concluding that the cost of access is simply too high. Their alternatives, the costly, personalized care of DPC, the aggressive search for functional medicine, or tragically, the avoidance of care altogether, are all symptoms of a system that prioritizes its own administrative inertia over the well-being of its patients. The veteran community is demanding dignity, timely access, specialized competency, and continuity of care. Until the Department of Veterans Affairs can fundamentally restructure itself to deliver these basic necessities, the exodus will continue, and the true cost of this failure will be measured not in budget line items, but in the lost potential and shattered lives of America's heroes. We must demand accountability and radical reform, because a nation that cannot care for the warriors it creates is a nation that has lost its moral compass.